so that people can join us at their convenience. But welcome. This is the August session of Sickle Smart Summer. This is our fourth and final summer session. We are very excited because we are focused on our local homegrown backyard in Minnesota. So we're going to be talking with a number of individuals that I'm very excited to invite to our table. Our first up will be Erica Barnes. Erica is an amazing person. She began her career as a speech language pathologist with a focus on stroke and brain injury recovery. Her entry into rare disease advocacy began when her youngest daughter, Chloe, was diagnosed with metachromatic leukodystrophy, in 2010. Following Chloe's death, Ms. Barnes co-founded Chloe's Fight Rare Disease Foundation, whose mission is to raise funds for rare disease research and awareness for the barriers to care in the rare disease community. We are excited because it is because of Ms. Barnes's hard work that we now have a rare disease advisory council in the state of Minnesota. And we are excited about the things that we have already done, the things that we are going to do, and the lives that it'll impact. So without further ado, I'm going to introduce her. Please know that you can jot your questions down right there in the chat box, and we will reconvene at the end for questions and answers. If you are on Facebook Live, feel free to put your questions in the comment box as well, and we will work on getting to those questions also. After Erica Barnes, we are excited to also have Sondra Rosendahl. She's a licensed genetic counselor with the state of Minnesota. And after that, our keynote speaker, James Burroughs, the Chief Equity and Inclusion Officer at Children's Minnesota. So we are here till about 12 noon. We do try to respect your time, but we know that some discussions become quite robust. And so if we go over a little bit, we certainly hope that you can continue to join us. So as we move forward, Erica Barnes, go right ahead. We're excited to hear from you.
Thank you. Thank you so much, Ray, for that great introduction. And I'm going to just pull my screen up. Forgive me, it might take just a second. Can you see my screen, Ray?
I sure can.
Perfect. Okay. So let me just start this. There we go. Okay. So as Ray said, I am I love the way that we're framing this talk, sort of starting with a broad view in Minnesota around the rare community, and then kind of funneling down into specific issues with sickle cell, because many of the issues that we'll talk about, and as I go through the theme of the presentation, you know, the rare disease community, even though it's very broad, a lot of the issues that I'm going to touch on affect all rare diseases, regardless of what your specific diagnosis is. So the presentation title for today is Rare in Minnesota, Seeking to Build a Unified Voice. And that has really been the driving force of a lot of the work that I've done in the last few years. As Ray said, I'm going to wear two hats through this presentation, and I'm going to put one on and talk, and then take one off and put another one on. And the two main hats that I wear in reference to rare diseases is I administer the Chloe Barnes Rare Disease Advisory Council here in the state of Minnesota. That's housed at the University of Minnesota Medical School. And we're a young council, but we're just getting our work started. And then the second hat that I wear is as the Rare Action Network State Ambassador. And that is an initiative kind of under the umbrella of the National Organization for Rare Disorders. So those are sort of my two hats. And I thought I would start by telling you a little bit about my journey into the rare community. So my journey really started it's been about 10 years ago now. And it started with the birth of my second child. So this is a picture of my daughter, Chloe. And Chloe was born in 2008. And when she was born, we had there was no indication at her birth that there was anything wrong with Chloe. The delivery was, aside from the fact that she was 10 pounds, there was nothing unusual about her birth and delivery. She got a clean bill of health from the newborn screening that she did in the hospital. There were no concerns from her pediatrician. And so she was our second child. So we just thought of ourselves as a really typical, young family in the state of Minnesota. And it wasn't really until around her first birthday, a little bit more toward 14 months, that I started to have some concerns about Chloe and about her development. Little things like she woke up a lot at night crying, and it didn't seem to be just a normal, needy cry. I was picking up that she just seemed uncomfortable. In addition, she kind of started, some of her developmental skills started to really plateau right around 14 months, and she just kind of seemed to be kind of stuck developmentally. So I brought the concerns up to her pediatrician. Her first pediatrician really wasn't concerned. But as Chloe continued into her second, getting close to that second birthday, my concerns just got more and more intense. And I really wanted the pediatrician to be a little bit more aggressive to figure out what was going on with Chloe. She didn't walk. She seemed to just, what I kept telling him was, she seems to want to do things in her brain, and she can't seem to do them physically. So things she looks like she wants to do, she can't do. So long story short, the first pediatrician in my relationship, unfortunately, became not good. And so I sought a second opinion at Children's Hospital in Minnesota, and she eventually was diagnosed with this very rare, very aggressive neurodegenerative disease. And the picture that I'm showing you here is of Chloe getting a bone marrow transplant at the Mayo Clinic. That is my husband doing a puppet show for her to counteract the boredom of being neutropenic and stuck in a hospital for days on end. So that is a picture of Chloe going through the bone marrow transplant. And Chloe actually passed away from complications of the transplant. And she passed away just past her second birthday in 2010. So following Chloe's death, my husband and I really got involved initially just with the metachromatic leukodystrophy community, just with the MLD community. We realized there was very little funds going into research, relatively speaking, to more common diseases. There was just a lot of gaps in the knowledge around metachromatic leukodystrophy. Certainly gaps in knowledge of general care providers, and through our experience, we realized that not a lot of patient providers or primary care providers understood how to diagnose metachromatic leukodystrophy. And so we started to advocate and fundraise. But as I really went through the process, and as I started to engage, of course, I started to meet other parents that were doing similar work, but in other diseases. I started to really see some commonalities as I met other parents. And I tell you, I would meet another mom or dad, and they would tell me the story about their child. And in my mind, I would say, gee, that story, all you have to do is swap out the diagnosis, and the barriers to care are very similar. And it seemed to always be the same when a family was faced with a rare disease. So my husband and I really started to observe that regardless of what the specific diagnosis was, if a family or if a person had a rare disease, we were hearing the same story replicated. We were seeing these barriers time and time again. So we got very interested. We sort of started to identify not just as families, as parents that had a child with metachromatic leukodystrophy, but as a family whose child had a rare disease. And that really kind of took our lens a little bit broader. So we got involved with the National Organization for Rare Disorders, and we started to really ask ourselves, what does it mean to belong to the rare community? And so I want to kind of acclimate you to the idea of the rare community. So the rare community is a very diverse community, but is not as rare as the term indicates. So to first just give you some, to acclimate you to and familiarize with some of the facts and the statistics, the definition of a rare disease is any disease that affects less than 200,000 people in the United States. That's a United States specific definition. But you'll note that it is purely a prevalence definition. So a disease gets put in the rare disease category simply by how many people it affects in the United States. So because of that, it is a very diverse label. There are actually over 7,000 rare diseases that affect about 1 in 10 of the population. So when I heard that statistic, it really made me realize that yes, if we're thinking about diseases individually, if we're thinking about these diseases individually, it affects a very small siloed population. But if we take a step back and we think about rare diseases as a category, all of a sudden that's a significant population in the state of Minnesota and in the United States. Another fact about rare diseases is about 80% of them have a genetic basis. So there is a little bit of commonality beyond just the prevalence in the fact that many of these diseases are genetic. 2/3 of the individuals currently living with a rare disease in the United States are children. So these are sort of just some of the basic facts. So when you think through this lens, all of a sudden, there's a population there that we can talk about collectively. And so, oh, sorry about that. Oh, goodness. So I want to talk a little bit about some of the characteristics of the rare disease community. So, you know, one of the things that I asked myself when I started to see these common, you know, when I started to understand that my daughter belonged to the rare disease community and I belong to the rare disease community is, what is the benefit? What is the benefit of thinking about the rare community collectively? Why even label somebody as part of the rare disease community? And what I started to realize when I thought about it is that even though it's a very heterogeneous population and there are 7,000 different rare diseases, there are some strikingly similar barriers to care. So we have a lot of the same barriers to care. And I want to just acclimate you again to some of these very common barriers. So the first thing that is strikingly common in the rare community is that the average rare disease patient waits for 6 to 7 years to receive a diagnosis. And again, this is, you know, there's a lot of variation to this. Some rare diseases, those communities have developed a pathway and they're able to get diagnoses more quickly. And some of the rare disease communities wait far longer than 6 to 7 years. Sometimes in a rare disease, normally these, you know, it's very typical for patients to not be diagnosed well into their adulthood. But suffice it to say that for the average rare patient, waiting a very long time for diagnosis is more common than not. In fact, it's so common that we refer to looking for a diagnosis as going on a diagnostic odyssey because it takes so long and there's so many barriers. Along with that, the average rare patient is misdiagnosed 2 to 3 times. So if you stop and think about this for a second, think about the implications of being misdiagnosed. So very often I hear stories about patients who receive, at the very least, they receive ineffective treatments, and sometimes they receive treatments that actually exacerbate their rare disease because they weren't getting the correct treatment. They were being treated for some disease that they didn't end up having. So not only is it a situation where when a rare disease patient is misdiagnosed, their actual underlying rare disease continues to, you know, they're not receiving treatment. So there's complications from that, but they actually have, you know, issues with being misdiagnosed. And so that's a very common statistic. The next thing about rare disease patients is we see an average of 7 specialists before being diagnosed with our rare disease. And again, if you think about this for a second and think of the implications, that represents, you know, multiple days off work, going to a specialist, multiple rabbit trails, the expense of seeing multiple doctors. It's just, there's a huge cost, social, emotional, and financial costs associated with having to go to multiple specialists. The next statistic is, you know, in the ICD-10 coding system, there's only codes for about 500 rare diseases. Now the ICD-11 has tenfold more codes, so that's great. But again, not having a code for your rare disease, the practical implications of that is reimbursement is very difficult. There's just, and just the fact that there's only 500 codes just indicates how not integrated into the healthcare system a lot of rare diseases are. And then the last statistic that is just really striking is that only roughly, and I'll put a caveat on this, I would say 5 to 10% of rare disease patient populations have an FDA approved treatment. So again, if you are someone who's living with a rare disease, you go through this very nightmarish journey of trying to get to a diagnosis. And then when you finally get that diagnosis, the likelihood that your provider is going to be able to give you any kind of treatment, that's not even a cure, just a treatment, is very low, because only 5 to 10% of rare patient populations have an FDA approved treatment. So that's just to kind of show you what some of those common barriers to care are across rare diseases. And I wanted to just show you this slide quickly to show you the heterogeneity of the rare community. So this is a list of, it's from Orphanet, which is a European database. This is just to show you all of the categories of what a rare disease could fall under. So we have rare infectious diseases, rare renal diseases, rare immunological diseases. So there is a lot of variation to the etiology of these diseases, but the striking nature of the barriers to care that all of these communities face is what I want to focus on. So then the question becomes, and the question became for me, how can we work together? If we have these barriers to care as a rare community, how can we in the state of Minnesota really work together? And there's a couple of things I want to talk about today that are ways that we as a community can work together regardless of our diagnosis. And the first one is identify and advocate for some shared policy priorities. And this is something that I'm putting on my Rare Action Network hat right now, because this is something I've been doing. And this is actually how I became familiar with the Sickle Cell Foundation and Ray's work. The Sickle Cell Foundation is one of those organizations that just were so encouraging to me, in that Ray and the Sickle Cell Foundation really gets it, that we can find ways to work together across our rare diseases, and we're stronger when we work together and when we raise our voice collectively than when we try to do things in a fragmented way and in silos. So sharing some of our policy priorities, working together. I pulled out in the bullets just a few. It is by no means comprehensive, the 4 bullets that I pulled out. And if you look at the right side of the slide, the National Organization for Rare Disorders does a state report card. And I know that the font is very small, and I'm not going to go through it comprehensively, but the National Organization for Rare Disorders has done a really great job of going state by state and really trying to identify what are some of those big priorities and how are the states doing in relationship to those. So one of the first things that many rare disease patient populations benefit from is newborn infant screening. And I'm happy to say that the state of Minnesota has a very strong newborn infant screening program. And so, but there's always improvements that we can make. And indeed, with newborn infant screening, with the influx of gene therapy for some of our patient populations, MLD included, which is what my daughter had, the opportunity to screen for some of these rare diseases, because we have treatments, effective treatments likely on the horizon, that just gives us a window of opportunity to expand the newborn infant screening program. So that's one really great public program that is hugely successful, and it has been just a game changer for the rare community for many years. The next kind of shared priority is the issue of step therapy, and making sure that protocols around step therapy, while we are all, very much in support of cost containment for our healthcare system, it also needs to work for all the patient populations. And, rare diseases in particular have often have specialty drugs that can be very expensive, but that can also be, the only treatment for some of these rare communities. So working together to make sure that the decision stays squarely in the hands of the patients and the providers is one area that we want to work together as a community. The third bullet is something that we specifically work for in the state of Minnesota, but I know a lot of states are following suit. And there's a lot of states that are trying to work on emergency medication administration protocols. So this is an issue where if you have a rare disease, and sometimes even more common diseases, but if you need medication for your disease and you carry those on you, we work to make sure that the protocols were updated as such that if you are having a medical emergency, that the EMTs on site, when they come to treat you, can administer your emergency medication for you and not have to wait till you get to the hospital. So that was a big thing that the rare community really pushed for a couple of years ago, and Minnesota really led the way. It was one of the few states that passed legislation for that. And then the last one is something that really COVID has highlighted for the rare community, and that's expanded and permanent access to telemedicine. Again, with the rare community, one of our characteristics is it is very likely that if you have a rare disease, you do not have a provider or a subspecialist near you that has an understanding of your rare disease. You're often receiving care either, if not, within your state, but further away, maybe out of state in another state. You have specialists that really understand your disease. And so making sure that patients have access to telemedicine so that they can access those experts and those providers out of state or maybe even out of the country is a big priority for the rare community. This state report card, you can find it on the Minnesota Rare Action Network website to just give you, if you want to do a deeper dive in some of the policy issues and how the state of Minnesota is doing. So to continue, so not only can we, with my Rare Action Network hat, not only can we address policy issues, but in addition, we can really, as a rare community, push for addressing the barriers within the healthcare system and some of the things that just are inherently not a good fit for the rare community. I was talking to an executive director from one of the rare disease organizations, and I love the way she said it. She said, there's common disease sense and there's rare disease sense. So some things that are common sense in the healthcare system for more common diseases don't make sense for the rare community. And I just thought that was really a clever way that she talked about that. And so one of the things that we're trying to do is really identify some of these unique barriers and really work together to figure out what some systemic improvements, whether it's mHealth or whether it's Children's or whether it's Gillette, what are some of these systemic barriers that we can address? And I've got a list of 4 of them, and I'm going to talk about them in depth here in just a minute. But I wanted to frame it around one of the things, and Ray was very involved in this, was one of the ways that we thought would be the most effective for addressing the systemic barriers would to really be to push for a rare disease advisory council in the state of Minnesota. So last legislative session, the rare community worked very hard to pass Senate File 973, which called for the creation of a rare council in the state. The bill passed unanimously, and one of the things I'm proudest to say is that there were 42 organizations that really worked. It was an absolute team effort, and the Sickle Cell Foundation was a huge part of this effort, but there were 42 organizations, and it was really made up of advocacy groups, hospital systems, industry. We also had some medical associations that endorsed this bill and really saw the value of creating a council. The council is cross-institutional, so we have representation from Children's Minnesota, HCMC, Mayo, the U of M, Gillette's, and the real intention behind this push was to say, okay, no one system can really address this issue of the rare community facing barriers. It's really going to take collective effort from all of our system and from the state. So our legislature really understood this, and the bill passed unanimously. So now we are in the midst of trying to realize some of those aspirations to address these barriers to care. And I want to just tell you sort of the 4 pillars of the Rare Disease Advisory Council, but I also want to say that even though this is what the state of Minnesota is doing, this is really something that would be applicable to multiple states. And indeed, I know there's a lot of states that are working on passing Rare Disease Advisory Councils. So I just want to say, if you're tuning into this and you're not from the state of Minnesota, these are things you can take back to your own state. And in fact, I was just looking at some policy in the European Union, and some of the things that we're trying to enact in the state of Minnesota, these efforts are going on even in Europe. So the first one, and I think the starting point for all of this, is really deepening our understanding of the rare disease patient population. We really want to understand from the patients, what are the barriers that they're facing? What are those common, and what barriers are unique to rare patients that maybe somebody with a more common disease isn't facing? We want to really look at some of the disparities in the rare community, whether that be some, racial disparities or demographic disparities. How is our rural population doing in some of these areas versus our more urban? Is it more difficult to get a diagnosis if you live in rural Minnesota versus if you're located in the metro area? And then really understand which of these barriers are priorities for the rare community in the state of Minnesota. Which things would they say, yes, these need to be addressed sooner rather than later? One way that we're doing this is we are in the middle of designing, we're very close to launching a patient survey that we're going to send out to as many rare disease patient populations as we can. And so we hope to get some information from that. And I'm sorry, I'm not going to go over every single bullet point, because just for the sake of time. Then the next one, our next pillar, is increasing access to and coordination of care. We really understand that for someone with a rare disease, often these diseases are very complicated and complex, and the specialists that need to address a specific aspect are usually, more times than not, spread across our healthcare system. So you might have a specialist at Mayo that really understands one aspect of this rare disease, and you may have somebody at Gillette who's really great at giving that care. So we really want to help the rare disease patient population in that coordination of care, and underneath that is transition of care. So, and I know this is something that affects the sickle cell community and many, many other rare disease communities, where when a child gets to the age where they need to transfer their care to the adult world, that transition can be very difficult, and it can often fall on the families to try to find the right specialists. So there's a degree of urgency to really addressing this for the rare community. And we also want to, underneath this pillar, I will say that we also as a council really want to understand from providers, what are some of those barriers? Why is transition of care so difficult for these rare patient populations? So we're also going to be launching a provider survey to get feedback from our wonderful professionals about what we can do better to make rare disease coordination and transition of care work better. The next one that I've already talked about, and I won't go into, I think I've said a lot about it, is we really want to see that time to diagnosis reduced. Waiting 6 to 7 years for a patient is just not acceptable. We need to find ways to reduce that time to diagnosis so that the patients are getting the care that they need in a timely way. And so we're going to address this in a lot of different ways. a combination of providing better resources to providers so that they know where they can go for information. We really want to make sure that we're utilizing technological tools better in the state of Minnesota. You know, bioinformatics has really, there's so much promise to artificial intelligence and bioinformatics. And then also just, we've made so much progress in the area of genetic testing. So making sure that those technologies that are out there are being applied to the rare space and that providers are able to understand how to utilize these. That's pillar number 3. And then the last pillar that we want to address is acceleration of research. So again, for me, the fact that there's only 5 to 10% of rare patient populations have access to any kind of treatment or care is just a stunning metric, and we want to do a better job. Now, I know that accelerating research is a very aspirational goal, but I think that there are things that we can do to help accelerate research, even just by nurturing the growth of some of the patient organizations in Minnesota, making sure they understand what they need, what the research community needs from them, how they can partner with researchers and really have what they need in place so that research can advance. I always say, one of the phrases that I always say is, and I think uniquely in the rare space, you know, advancement in research is often in the rare space predicated on a healthy and functioning patient community, so that those patient communities can really push the medical community and push the research community to prioritize their rare disease, and also that they can provide the information that the researchers need. So we really want to accelerate research for the rare community, because at the end of the day, we need more treatments and we need more cures for the rare disease community. So that's kind of a very broad, relatively quick overview, but I want to stay within my speaking time. I tend to go on and on. I want to leave you with this final slide when I can figure out how to get to it. I love this proverb. If you want to go fast, go alone. But if you want to go far, go together. And I know that that was the spirit behind the 42-member coalition that passed this piece of legislation for the Rare Disease Advisory Council. We know that we can go further when we're working together. And so I just want to encourage all of us to think about how we can improve the system for all rare disease populations and work together. So with that, I'm going to hand it back to Ray. I gave you 2 minutes. So thank you. And let me just. There we go.
Excellent. This is wonderful. Thank you so much, Erica. The information that you presented really gave a broad overview of where we are in our state with our rare disease work. At the end of the day, we're stronger together, and we have our unique aspects of our experiences within our diagnoses and even within our family structures. But we are a united voice in the state of Minnesota, and so many other states are also following suit in that, so that we can make a difference, we can change outcomes, and we can find a cure. And even before we get to a cure, we got to get to the diagnosis, right? And I really appreciate the fact that you pointed out people are waiting years to understand what's happening with their child. And that journey is a taxing journey on top of everything else about life. To not know what is happening with your child can really add a great deal of stress and strain to the household. So thank you so much. We'll move forward here next with Sondra Rosendahl. She is a genetic counselor at the Minnesota Department of Health working in newborn screening. I thought again that as we continue with the theme of Stronger Together, whether you are a community-based organization, whether you are a small business, or whether you are are another state level or local organization. It's really important that we link arms and we recognize that we have a shared journey in this. So I'm very excited to introduce Sondra. Sondra, I've made you you're a co-admin here. So you can turn your screen over to yourself and unmute.
All right, thanks, Ray. I have, you might have to help me with my sharing the screen. Oh, there we go. Click that. There you go. Can you see it?
We sure can. Go right ahead.
All right, perfect. Thank you so much for that introduction and for inviting me to come and speak with you all. As Ray said, I'm one of the JAC counselors at the newborn screening program here in Minnesota. I also happen to be the coordinator of our newborn screening advisory committee. And our advisory committee, I'm going to touch base with here because I think Erica had some lovely transition opportunities for me for going into speaking about newborn screening specifically for sickle cell disease, but I thought I would touch briefly about, kind of in general, newborn screening is unique for each state. And in Minnesota, we happen to screen for every condition that is recommended at the national level. Just within the past 2 years, we actually went before what the recommendations were when we added spinal muscular atrophy. So I like to think that we are here in Minnesota, on top of the game, so to speak. And we are, let me get my video on here. There we go. Hi. We have a really great advisory committee. Ray is one of our advisors on that committee, and so we're so glad that she could be part of it, as is Steve Nelson. I know he's on here too. So in Minnesota, we review conditions. There's certain criteria that needs to be met for newborn screening conditions to be added to the panel. One of them is that there obviously needs to be a test that can be done, and there needs to be some sort of intervention or treatment are kind of some of the key criteria for a condition to be added to the newborn screening panel. There needs to be something that can be identified in the newborn period, although that certainly has been kind of blurring the lines as of recent. In Minnesota, let's go to my next slide here. In Minnesota, we've been screening for sickle cell disease since 1988. And so every baby born in Minnesota does get screened for sickle cell disease. Again, in Minnesota, we have certain options that is different for each state. In Minnesota, we can opt out of newborn screening. Not many families choose that option, but it is one that exists. I would say there's probably less than 200 per year of families who choose that option, and with a birth rate of around 68,000. That's, as you can imagine, that's not very many. The screening test for sickle cell disease is very good and very similar to what a diagnostic test would look like. I have a picture there of one of our tests. We do 2 tests for our sickle cell disease identification. And if the test comes back abnormal, or what we would call positive, then an MDH genetic counselor like myself will then contact the baby's doctor, and then we provide kind of what we call just-in-time information to that doctor so that they can then contact the family and follow up on this result. We talk with the doctor about what the condition that came back abnormal was, what does it mean, how quickly they need to follow up on that result, and then we also provide them with some fact sheets about the condition. As Erica mentioned, there are a lot of conditions out there that are rare, and we screen for a lot of those conditions. We want to make sure that when the provider does contact the family, that they have all of the information that they need in order to answer all of the family's questions. So we send them a provider fact sheet as well as a family fact sheet that they can then give to the family to take home with them after they've had that conversation. And all of those fact sheets are on our website as well if you'd like to go check those out. When we are talking with the doctor, we do recommend for individuals who, again, screen positive for sickle cell disease, that they consult with a pediatric hematologist. And we recommend that happens within about 1 week. We want them to contact the hematologist so that follow-up testing and any other medical care that is needed can be started. After we have those conversations, we then have an MDH staff person who follows up with those with our specialists and the primary care clinics to ensure that follow-up was actually pursued. Through our testing that we do for sickle cell disease, we also identify sickle cell traits. It's just kind of the nature of the testing methodology. And previously, the trait results would be reported on the screening report and sent back to the hospital who submitted the specimen to us. Within the past few years, we have really changed that, and in that process was very much informed by the community and my colleague, Maggie Drian, and people working with her held some focus groups to really identify, what does the community want? How do they want to hear about these trait results, and what does that look like? And so through that, we've changed the way we follow up on those results. And follow-up currently includes a parent mailing. So we send families a letter letting them know about the trait result, as well as a fact sheet about that trait result so that they have some information about what was found, what is sickle cell trait, and what does that mean. And we also send a fax to the provider that's listed on the screening card with similar information. You can see I have an asterisk there, and that's because not all of the providers that are listed on the screening card are accurate. And so this fall, we will be taking some additional steps to try and confirm who the primary care provider is before faxing those materials, as well as a 9-month and 12-month follow-up fax. Again, to just try to make sure that the provider is aware of the fact that their patient has this trait result and can follow up appropriately and have a conversation with the family about that result. So as I mentioned, the trait process was informed by the community. We try to do other outreach. We've participated in the Juneteenth activities, and we hope to do more, but certainly COVID-19 has affected that. But hopefully after we find our new normal, we can engage with the community more. So I thought I would give some data about sickle cell disease in Minnesota. Last year in 2019, we had, and this first part is 22 what we call referrals. Basically, that means that we've had 22 positive results, and that's for all hemoglobinopathy results, not just for sickle cell disease. And you see at the bottom there, we had 15 individuals diagnosed with a sickling disease. You'll see that there's some that were lost to follow up, whether they refused or they moved. And I'm happy to report that those were not ones with sickle cell disease, but certainly ones we still want to check into. But all of those with sickle cell disease were connected to a specialist. The vast majority of our results are FS, F being fetal hemoglobin and S being sickling hemoglobin. So about 69% of our cases have been FS. The fetal hemoglobin will disappear with age, and so those individuals who have FS will be left with just the sickling hemoglobin. So those are our kind of classic sickle cell disease cases. And then you can see followed by that is our FSC results. So again, the F goes away and you're left with the SC disease. So how many babies are identified with sickle cell disease each year? I have a prevalence chart here that shows what we have here in Minnesota. Overall, about 1 in 3,000 Minnesota births have a confirmed sickle cell disease, which is about in line with one of our other conditions, cystic fibrosis, and both of those two, as well as one other conditions, are probably our most common conditions that we screen for on the newborn screening panel. There is an interesting drop in cases in 2019, so it'll be interesting to see what 2020 data will show. It's kind of how data works out. There's fluctuations, but overall about 1 in 3,000. So where do our babies with sickle cell trait and sickle cell disease live? So the majority of Minnesota counties have 1 or more newborns born with sickle cell trait, and that's based off of what county they were living in when they were born. Certainly people move, and so that's not reflective of where they are today. So I just want to clarify that. However, most cases of sickle cell disease are born in Hennepin and Ramsey County. So I just wanted to share that map. We recently started to look at this data, and we hope to, again, in the fall, do kind of an education push to our providers about how they really need to be informed about these conditions, because I think there are some providers out there who think that this is just something that they need to, people in the Twin Cities need to care about, but that's not the case, as you can see through these maps. So once a child is identified with a sickle cell disease, we pass that case along to our long-term follow-up team. And they have essentially 3 main goals. One is to assess the long-term outcomes. And some of the questions they ask, is newborn screening sustaining the primary aims of preventing mortality and mitigating morbidity? And what are the benefits of newborn screening throughout the life of an individual, as well as to the family and society? They also want to assure connection to information and resources and services available to those families, such as the Sickle Cell Disease Foundation. So they send out a folder of information to these families once they've been confirmed, to make sure that they know and understand what is all available to them here in Minnesota. And third, and but certainly not last, is evaluating and improving our systems. So working with our sickle cell disease partners to improve the systems and care for people living with sickle cell disease. One example of a partnership to better understand how sickle cell disease is impacting families is through a grant that they recently received from the CDC that we're hoping we can better understand sickle cell disease and its impact on families, and I will talk about that next. So in late spring, early summer of 2019, the CDC, or the Centers for Disease Control, posted a funding opportunity for capacity building for sickle cell disease data collection. And we applied for that grant and received notification in September 2019 that we were selected to receive that planning grant. And on this slide, you can see all of the partners that are part of this project. So it's definitely a group effort and something that we would not be able to do alone. So I'll talk a little bit about what that data collection program is. So the Sickle Cell Disease Data Collection Program strives to improve the health outcomes for people living with sickle cell disease. We can do that by documenting health information of patients with sickle cell disease in the United States over time. The program can then identify critical gaps, whether it's to diagnosis, treatment, or healthcare access. In working with the CDC, we hope to answer some of these questions. So, where are people with sickle cell disease living? As I mentioned before, I showed that graph. That's where they were born, but where are they living now? And how are they receiving their health care? and what can we better understand about the transition from pediatric to adult care, and what are some gaps in those care, and how can we improve those? As newborn, sickle cell disease is on the newborn screening panel, so we do have early screening and early diagnosis, unlike some of the other rare conditions, but we still have work to do. And we know that individuals with sickle cell disease are living longer, and now is a good time to study, the health of that child across their life course. So that is our goal. So California and Georgia are actually two states that have been involved in this sickle cell data collection program since the very beginning. And I wanted to share one of their examples of their success, and hopefully we'll have our own slide to share down the road of our success as well. So hydroxyurea, as I'm sure many of you know, was approved by the FDA in 1998 for treatment in adults, and then in 2017 for treatment in pediatric patients, and it can really help decrease the complications of sickle cell disease. However, not as many people were taking this medication. As you can see on this chart, in 2006, the percentage of hydroxyurea use from individuals receiving Medicaid was only 23% in California and 24% in Georgia. And through efforts that they have done to increase the use of appropriate use of hydroxyurea, that percentage increased in 2016 to 36% and 40% respectively. And they were able to identify through surveys of both patients and providers some of the barriers surrounding that. And so then again, they were able to kind of know what the barriers were and address those barriers to increase that use. So we have been learning from California and Georgia, and since we have this planning grant now, they'll be able to provide us with some assistance as we continue to move forward with our efforts. So Minnesota was one of 7 new states that was awarded this funding. And it was from September of 2019 through September of this year. And again, this was a planning grant. And there was really 2 outcomes that we wanted to obtain. The first one being increased standardization of methods for data collection. So there's a lot of data out there, all housed in different places. And so how can we make sure that we are collecting the right data and sharing that data? So some of the strategies for achieving outcome 1 was to participate in some capacity building sessions. So we had people working with the CDC in California and Georgia to learn from them through those sessions. And then initiating and developing data use agreements. So for example, being able to gather data from vital records and hospital discharge data and Medicaid claims, newborn screening data, and data from our specialty clinics. And then also identifying, what are our capabilities for building a database and how best to collect that data. And then outcome 2, we wanted to increase understanding of the utility of the sickle cell disease data among patients and family members, healthcare providers, and policymakers. So by doing that, we wanted to, or by achieving that, we wanted to convene a multidisciplinary team and engage with our sickle cell community and our stakeholders. So what is our progress to date? So thus far, we've been working on establishing those partnerships. As you saw on that one slide, there's a lot of individuals who are interested in partnering to see improvement in improving the outcomes for these children. And so, bringing all of those partners together and establishing those strong partnerships between all of them so that we can implement this state sickle cell disease data collection system. And data sharing agreements, we've made some progress there as well. So already in place, we have data sharing agreements for state maintained data. So you can see on that graphic there that they want to get newborn screening data, that they have access to hospital discharge data, vital records data, and emergency department data. So again, all of these different things kind of funneling to one place rather than it being housed at multiple sites. We're currently in process for getting data share agreements for clinical data and Medicaid data. And it takes time, but you know, we're happy with the progress that we've made so far. And as far as like next steps go, we do have a progress report that's due to the CDC in December. And we have recently applied for the next round of funding to continue our efforts on those. So again, the first one was for planning, and you know, hopefully with the second one, we'll be able to do even more to then take what we've planned and implement. I just want to take a moment to thank those who contributed to this presentation. Nicole Brown is the supervisor over at Long-Term Follow-Up, and Jennifer Hauser is really the one who's leading all of this effort with the sickle cell disease data collection program. And I know she wanted to be here today, but she has been reassigned to COVID-19 work. And so she asked if I could step in, which I was happy to do because I want to make sure that we get our message out there for her and for MDH. So yeah, thank you so much.
Thank you, Sondra. This was really comprehensive. There's so many things that are happening around the U.S. specifically that Minnesota is really beginning to take form and to really look at ways that we can approach not just rare diseases as a whole, but then also taking an equitable approach to individual diseases to ensure that needs are being met across each of those communities. So this is exciting. The fact that we received the CDC surveillance grant to really begin to build the foundation and the infrastructure so that we can have sustainable data tracking so that we can get to a cure. So thank you very much.
Yeah.
I'm going to move your, can you unscreen share?
Yes.
Awesome. Thank you so much.
You're welcome.
And then next up, by the way, if you have questions, please be sure to put them in the comment box, or if you are watching via Facebook Live, put them in your comment box wherever you're watching. Here on Zoom, you can put them in the Zoom comment box as well. Next up, I am extremely excited to talk about our keynote speaker, this James Burroughs. He is the Chief Equity and Inclusion Officer at Children's Minnesota. For those who may not know, Children's Minnesota is the leading children's hospital for sickle cell in the state of Minnesota. Approximately 94–95% of the pediatric population receives their care at Children's Minnesota. Now, James, as the Chief Equity and Inclusion Officer, which is a fairly newly created role at Children's, but it's designed to help the organization advance equity and inclusion in the delivery of quality care for patients and their families, as well as foster an employee culture of inclusion where every employee can bring their full selves to work and every community member feels like a valued partner. I think many of us know what it feels like to not feel embraced by our work community. So the work that he's doing at Children's is so important. He has extensive experience leading equity, diversity, and inclusion efforts for the organizations that he's worked with. He has developed workplace equity, diversity, and inclusion training, policies, and so much more. I am so excited to introduce my friend, my colleague, my mentor, James Burroughs. James, take it over.
Thank you, Ray. Thank you, Ray. I want to warn the audience, I'm dangerous today because I'm doing all of my IT and video production myself. So first of all, can you hear me?
We can hear you.
All right, got a headset going. And can you see the slides on the shared screen?
Okay, I can see them.
Okay, we're good to go. We're good to go. I want to thank Ray and thank all for the Sickle Cell Minnesota Foundation for allowing me to be the keynote today. I want to say thank you in advance for putting questions in the chat box for not only me, but our two wonderful panelists who preceded me, who gave us a lot of great information. It's hard to do a virtual presentation, and the presenters before me can attest to that, because you don't see the wonderful faces. You can't acknowledge the head nods, but you can get questions later and handle those. So I encourage you all to ask myself and other panelists questions as well. The other thing I want to say is Ray is very loved, because today and tomorrow is my golf championship. So I should be playing golf at New Richmond Golf Course right now. But I committed to Ray, and I committed to a wonderful young lady who you'll meet later in the slide presentation, Teresa Burroughs, who's my daughter, who has sickle cell disease. So I am here in spite of wanting to be on the golf course. So without further ado, I'm going to jump into it. I want to tell you a little bit about who I am. Then I'm going to talk a lot about health equity. And I really want you to focus on the question, are you ready? I really want to encourage you to say, okay, we've not only had health disparities with COVID-19 exposed to us, we've also had other disparities exposed to us by the murder of George Floyd, which happened 12 blocks from one of our Children's Minnesota hospital locations. And the world took notice of Minnesota, not in a positive way, but in a negative way, about the inequities around policing, the inequities around income, the inequities around schooling, education as well. So my question to you as you think through this and we talk about it, are you ready to do something about this? I want to start off with telling a bit about who I am. As Ray said, my role is Chief Equity and Inclusion Officer at Children's Minnesota, but much longer before that. I was born in Detroit, Michigan in 1967, and I was born during the time of the Detroit riots. And I'm going to give you a little bit of summary. The Detroit riots were caused by a police incident at an after-hours club where the police violently shot and killed, I think about 11 to 12 people at the time, and they were all Black, and the policemen were all white, and the riots were based upon not only that incident, but other incidents of police brutality and discrimination. Because remember, in 1967, there were a lot of times that Black people and couldn't go places where white people could, and that was enforced by law enforcement. And I bring that to your attention because if you fast forward to 2020, we're fighting some of those similar or same issues. We're dealing with some of those same civil unrest. And I want you to know that when I was born, the riots happened in July. I was born in October. My family, my sibling, my sister Kim, and others, we were in the midst of that. And the riots caused a couple of things. It caused not only civil unrest, but it caused gentrification, because a lot of folks who were majority white moved out of the Detroit city limits and moved into other areas of the suburbs as well. So I grew up in a place where my diversity was 99% Black people, but I saw Black business owners, Black mayors, Black doctors, Black nurses. And that's important because I want you to realize that when you see images of success that look like you realize that from an equity lens, you can be anything you want to be. And when we talk about health equity, sometimes it doesn't start with the doctor's visit or the time they come into the hospital. It's the environment that they grew up in. It's the environment that you see every day. And it's those positive things that you're exposed to as well. More a little bit about me, my shared experiences. The gentleman to the left, I will give you a quiz, but is Martin Luther King, and the gentleman to the right are Spike Lee with the purple suit on and Samuel L. Jackson. They share a similar experience to me, that they're Morehouse men. I'm a graduate of Morehouse College, a proud graduate of Morehouse College in Atlanta, Georgia, which houses about 2,000 mostly African-American men. The college has been in existence since 1867, started as Augusta Baptist College and been Morehouse College for many years now. And proud of that fact because a lot of times when you see images of Black men in society, this is another health equity information for you. A lot of times you see negative images. You see negative images in crime, you see negative images in violence, but you don't see the positive things of a Morehouse College. And these gentlemen are not the only successful graduates. The first Black Surgeon General, Dr. David Satcher, was a Morehouse graduate. The former Health and Human Services Secretary under Bill Clinton, Louis Sullivan, a Morehouse graduate. Edwin Moses, the multiple time Olympian, Morehouse graduate. And that success is important because once again, health equity is about images of success that you need to see. And when our young people see those and our adults see those, they have a different image in how you treat people as well. This is the little one here, my daughter, Teresa Ann Burroughs. We had the opportunity several years ago, so she's much taller now, to throw out the first pitch for Jackie Robinson Day at the Twins Stadium. I asked the Twins if I could do it with her because we wanted to make sure that we could do things together. Because of her sickle cell, I wanted her to know she could do anything anybody else could do. And one of the things that, we don't talk about in the data on sickle cell is we still have to encourage our young people, and then when they get to be adults, that they can do anything they want to do. Now, they have to address their health needs, and if they need to hydrate, if they need to rest more than others, that's fine, but they can do anything. So she was happy. She threw the first pitch out, and for the record, my pitch across the plate, and it was a strike. So we were happy that day as well. This one is an interesting slide because it's going to require more explanation than normal. This is Teresa, I, and her mom were asked to be part of Memorial Blood Center because, as you know, sickle cell patients are in need of blood and transfusions quite a bit, and we want to make sure that we have a high rate of blood in order to have those transfusion needs met. Memorial Blood Center, I joined several years ago, their volunteer advisory board to make sure that families like me and other Black families knew the importance of Black people donating as well, because that's an important blood source we have for our need for our community. I have since left the Memorial Blood Center board, had a great experience there and working with folks, and I'm now on the Red Cross board. So when you see this slide next time, it'll have some red and white in the background. And I think Phil Hansen, our CEO, is on here, and our board chair, David Hamlin, will be on this call. So we're going to make sure we have some Red Cross stuff the next time. And my thing is this, the Red Cross, I want to give a shout out to, they're doing some great work around sickle cell. They're doing some great work around diversity inclusion. And Ray, just so you know, they have committed to being a partner with Sickle Cell Minnesota Foundation, and we're going to figure out what that looks like going forward. So that's what, and Teresa can be seen on some of the billboards too, or when we do have sports again, some of the Jumbotrons as well. That was an old picture of her. This is a new picture of her. She's now 8 and grown with like long hair, and went to the beauty parlor. So I always show that the younger picture. Like, oh, she's so cute. She's still cute, but she's older now, and she doesn't want as many kisses and hugs from daddy, but that's okay. We're still loved. So she's 8 and doing very well, managing her sickle cell disease with hydroxyurea, with great care from Ray and also Dr. Stephen Nelson, who's her doctor at Children's Hospital as well. So we're very appreciative of that. So I want to tell you a little bit about me, about who I am before I get into this work of equity, health equity, and also structural racism. I want you to realize this, a couple things before I jump into this. One is you're going to learn a few things today, but by no means will you be an expert in any of these things after this 15-minute session. So I'm going to encourage you to do some more research, read some more materials, use the feature of Google to research around health equity, what it means and what it's about. The second thing I'm going to encourage you to do is, one of the learnings that I've had around health equity is, if you stay in isolated groups where you are the only one or the only person, or your group is, of a particular race, so you have a great group that's not racially diverse, you don't learn as much around these things unless you don't expand that group to be more racially diverse. I encourage you, as you're learning, as you're Googling, as you're researching, to expand that diverse group and have conversations with folks about how structural racism or systemic racism as well is impacting their communities and them individually. So real quick, I'll tell you a little bit about Children's and how we're addressing this. We're looking at it from a comprehensive viewpoint. We're looking at equity from the lens of how does it line up with our children's values. So we have values of the hospital system, making sure that equity inclusion is included in that value. How are we teaching from a learning and development standpoint our leaders? And I'll talk a little bit about that later, but our leaders from our senior leadership team have just gone inclusive leadership training for 4.5 hours. And our top 250 leaders will go through that in the next several months. And eventually that will cascade down to all of our employees. So we'll have a common language, common understanding, common expectancy around competencies and behaviors around equity inclusion, and then hold each other accountable for that. That talks about the leadership competencies as well. We also want to make sure that we're evaluating how we're doing. So we use this thing called the Intercultural Developmental Inventory, which is the IDI, and it determines, cultural understanding and a cultural agility. And we use that to assess where we are. And I encourage you, as you're learning about health equity, learn about equity, have some assessment tool to measure how you're moving this work forward. We also have at Children's a 45-member Health Equity Council that Ray is a part of, and so is Dr. Nelson as well. And that council helps guide our work around community engagement, accountability and metrics, what these things called respect and dignity learning reports I'll talk a little bit about later. And then also too, just overall guidance around how we are performing. And then the last thing is performance metrics. We make sure that we have identifiable goals at Children's around equity, inclusion, and diversity, making sure that they're part of our operational plan that's led by our CEO and COO and top leadership team, and the board holds us accountable as well. One of the things I want to give a encouragement to, that what organization you're working with, it has to be, this work, health equity, has to be infused throughout top leadership and throughout the organization. Our board, governance board, and our foundation board at Children's have been very active in this work, and I've presented to them several times around how the board can be engaged in this work as well. So those is the framework about how we operate at Children's as well. I won't spend a lot of time here, but we have a vision and mission statement for our work. We want to make sure we have an inclusive and safe environment, that people feel, our patients and families feel valued and respected. And then we have a culture that respects and also appreciates and serves in an equitable way people from different backgrounds, because our patients and families are truly amazing. I want you to think about the data you've heard earlier about rare diseases, and then also from the young lady from the state around sickle cell. You can have all of those conditions. You can have been diagnosed with sickle cell. You could have had a newborn screening. But if you come to a place that's not treating you or valuing your family, and you're getting service that you realize that you're being treated differently because of your race, your ethnicity, possibly your gender identity, possibility your, if you're a person with a different ability or disability, you are not going to want to come back to that place. You're not going to want to partner with that place. You're not going to want to get health care. You're not going to get vaccines for flu and other things as well. So when we talk about health equity, we talk about this work, it's very important because we can collect as much data as we want, or if we have an environment in our health systems, not just Children's, but other places, our families won't want to come and get served and partner with us on that. So it's very important that we do this work. This is an important slide here because I want to make sure that we distinguish between, we talk about equality and equity. I'm going to go through the whole 4 prongs here. It's on the internet, so it's not proprietary to Children's. And if you want this slide deck, I'll make sure that Ray has the opportunity to share it with you as well. The reality I'm going to say for last. So social justice on the far right side, that's what we want to make sure we have no barriers to success. In a social justice environment, we want to make sure everybody has equal access. They have equal access to resources. They have equal access to people, money, and those kind of things. So everybody has that access. And you see those young people that they have access, no barriers to see this baseball game, which is a metaphor for life in this particular slide. Equity, when you look at the equity slide, you have a little short person, a medium-sized person, and a taller person. When you talk about equity, the simple definition of equity that I like to use, definition of equity, is it gives everybody what they need to be successful. If you are the size of the young man in the purple, you need 2 boxes to see over this fence or barrier. If you are the size of the person in red, you need only 1. And if you're in the blue box, you don't need any boxes. You can see that perfectly. Equity is not about giving, if you look to the next slide about equality, everybody the same thing. If you have everybody the same box with the same information, the same resources, you see there, the little kid in the purple can't see, the red kid can barely see, and the blue kid doesn't need the box, but he is even taller than the other kids as well. Think about that as far as resources and how we operate in reality. And that's the slide all the way to the left. In reality, we've had this thing called systemic racism, slavery, colonialism, and conquest of taking other people's land for many years, over 400 plus years. And that has led to a reality that we have a system that is built upon whiteness, and that whiteness has allowed groups who are white, and not individuals, but just a whole group, to have the majority of the wealth, the majority of the political positions, the majority of, you name it, whiteness tends to be reflected in those things that have that because of slavery, because of those 400 plus years of oppression. So that reality is there are many boxes in that particular box when it comes to discussion of whiteness. The reality is the little kid in the purple, which could be many different groups of color who have been oppressed or been subject to oppression, their reality is starting in a hole. And that hole, I'll give you an example. When we talk about equality or equity as it relates to housing or employment and voting. So if we didn't have a Voting Rights Act until 1965, so we didn't have the ability to have housing that was non-discriminatory until the mid-60s. We're only in 2020, so this country was established in 1776, but before that, there were 400 years of slavery that started in 1619. So you had a head start amongst people who were in the particular group dealing with whiteness, who are now able to say, hey, we have all of these things. Equity doesn't mean giving everybody the same start, the same start at the finish line. It means doing something different to address those years of oppression. I don't want to leave out my Native brothers and sisters as well, because this country is the home of Native Americans and was originally settled by them and stolen from them by those that we talked about before. So if a country is stolen from you and you realize if you're Native American why you're only 1% of the population is because you were exterminated, and those things have to be addressed as far as equity and social justice and equality. These are not easy subjects to talk about, so I want to make sure that as you move forward and as you learn more about this, open yourself up to having difficult conversations that may lead to not necessarily arguments, but heated conversations about how we got to where we are as a nation and a country and what we need to do to move forward. I'm not going to spend much time here, but at Children's and other places, I suggest you, when you talk about diversity, a lot of people don't know what that means. They think it's just race. It's more than that. It's gender, age, sexual orientation, gender identity, religion, your economic status, your thinking style. I'm going to tell you something that's not much of a secret. So Ray has a young man, Trey, who's her son, who has sickle cell disease. I have a young daughter, Teresa, who's my daughter, has sickle cell disease, and we're both of African-American or Black descent. We are not the same. We're not monolithic. We don't think the same. We don't work the same. We don't operate the same. We have some tendencies that are alike, but for the most part, we're very different. And when we talk about diversity, I want you to realize that, because a lot of times we talk about making sure we have a diverse patient and family base and also employment base. We want to make sure that we don't lump people together just because of their race. They still have different thinking styles, working styles, and things like that as well. And we highlight that at Children's. Real quick, what is health equity? We hear this term a lot. I love the Robert Woods Foundation simple definition that it's fair and just opportunity for everybody to be healthier. What it does require, though, is some action around removing poverty, discrimination, lack of access to quality employment, education, housing, and other things that get in the way of not having proper health care. We talk about these sometimes in healthcare as the social determinants of health. Those things are barriers that, through systemic racism, have allowed certain populations, in this case I'm talking about Black people, to not have a safe, quality environment. And that goes for our Latino brothers and sisters, and our Asian brothers and sisters, and Native as well. Because of that, we don't have health equity, we have health inequity. And Minnesota leads the country in inequities around education, health, and also economic empowerment for around racial lines, and especially with the Black population. Structural racism and systemic racism, I really want you to just focus on realizing that these are things that are caused by historical, political, and cultural institutions. I mentioned a few of them earlier: colonialism, slavery, Jim Crow, segregation, prejudice in housing and redlining, and racial covenants. And those are things that led to having the majority of places like Edina, Edenport, and others be populated by white people, and historically having white economic opportunities there because of those redlining banks and also racial covenants and real estate deals that didn't allow people of color to buy land or property in those areas. So those systemic things or structural things lead to the racial inequity we talk about. Those are unfair practices and policies, and we got to look at those and address those moving forward. And some of those are not as, historical. So I'll give you one real quick. At Children's, we were trying to diversify our workforce. And a lot of times when we are trying to get great candidates, we say we want a person to have 5 to 10 years of experience in healthcare. Well, if we have a system that has been discriminatory against people of different races for many years and hasn't hired in that space, and then we require them to have 5 to 10 years experience in healthcare, we won't find those people from racially diverse backgrounds. So simple things like that, looking at policy changes and looking at changes of how we look at experience and education as well is important. Racial equity is where we want to be. We want to make sure that we get to a place where in healthcare and other places, race no longer determines the outcomes of health or wellness. We want to make sure that you can thrive no matter where you live. Unfortunately, if you have a certain zip code, we can predict, at least in the Twin Cities especially, how you will do academically, how you will do health-wise, and how you will do economically. We want to get to a point where we're not predicting that. And that prediction by zip code is typically by a racial zip code about having a majority diverse population racially ended up with lower outcomes and more disparities as well. And the last thing here is very important. We need to acknowledge and account for past and current inequities. When you hear about health equity, you hear about racial consciousness or racial justice, a lot of people want to start with where we are now in 2020. And I'll give you an example about George Floyd's murder. When George Floyd was murdered, people would say, okay, well, that was terrible, but why are people rioting or having civil unrest just because that one murder? Well, the past and consequences are before George Floyd, there was Philando Castile. Before Philando Castile, there was Jamar Clark. In between there was Marcus Golden. In between there was Breonna Taylor. There was also Ahmaud Arbery recently. So it's not just one incident, it's past accountability and inequities that lead to the things that we need to address in an urgent matter right now. Real quick, these are some ideas or things that we use at Children's to address health equity and definitions: inclusion, making sure everybody feels valued; diversity, we talked about; equity, we talked about as well. Everyone has their best to do their best work and receive high quality care. Access is important: quality employment, contracting, partnerships, and solutions are joint together. We do that together. The access piece I want to highlight real quick. One of the things that Children's is doing as well, and I suggest other entities do, is we're partnering with communities that have been negatively impacted by us over the years. So partnering more with the Black, Latino, Asian, and also Native community, and also too investing in working with them as contractors. So if we want to say that we're going to sit in the Phillips neighborhood and serve the neighborhood, we should be spending our dollars in the neighborhood to support businesses that are owned by people of color as well. And that's something that we're very intentional in doing. When we talk about health equity, I want to leave you with some tools. So one is, you got to ask yourself when you're discussing this, what are you willing to do to act to get success? I always talk about equity actions. If you're willing to just talk about a solution and talk about health inequities and talk about sickle cell disease and its impact on community, that's one thing. But if you're also willing to say, you know what, we're going to do something about it, what are your action plans? The other thing is your budget. If I look at the state's budget and I look at the MDH's budget around healthcare, and I see, and I think the young lady mentioned from the state, cystic fibrosis and sickle cell. And if I put those budgets side by side as far as how much research and investment is being placed in sickle cell, which impacts highly a larger people of color community, especially Black community sometimes. And I look at cystic fibrosis, which impacts the white community, and I see the budgets are much different. And if I see cystic fibrosis is much higher budget or investment than for sickle cell disease, that lets me know that that's the equity question I need to ask. Are you walking the talk, or are you just saying you want to invest in sickle cell and not doing it? And then also to aim high for goals that we may not be able to reach, but I'm always for a 40% goal that we fall 10% short of and hit 30%, rather than a 5 or 2% goal that we hit, making it easy. Also around health equity, changing the workplace culture is important, and also identifying structural racism, systemic racism, talking about white supremacy as well. I must shout out Dr. Mark Gorlick, who's our CEO at Children's. He talks about white supremacy, he talks about systemic racism and talks about what we need to do as leaders around it. And he does it not when the chief equity inclusion officer is always around. He does it as part of his leadership. So that's something in changing the culture and organizations for our health equity and addressing the needs of patients and families for sickle cell. We got to make sure we can talk about these tough subjects as well. And I also want to shout out Ray and also Dr. Nelson, who do this on a daily basis for patients that are seen at Children's Minnesota, because without doing that, they realize that we're ignoring a patient population and we're ignoring some barriers for them as well. So they do a great job at doing that. Learning and development, I talked a little bit already about educating folks around, what is this thing called equity and inclusion and how can we do better at it as well. I'm going to leave you with a couple of things as well about health equity lens. When you're talking about how we can do better at serving patients and families around sickle cell disease, we have to talk about and understand systemic and structural racism. We have to understand also too that this racism causes real life trauma on patients and families. There are many studies that the Pediatric Association has just done and others have done as well, realizing that racism has implications on health and wellness of not only our adult patients, but also our younger patients, our pediatric patients as well. Acknowledging that is one thing, but then changing the environment and culture is another to make sure that it doesn't have a negative impact on their potential growth and wellness in the future. We also have to make sure that we understand cultural differences and characteristics and religious values and customs. One of the things that we do at Children's as well is try to make sure we understand the needs of our different populations. We have a young lady, her name is Halal, and she has a business that creates custom-made hijabs. And hijabs are the headwear that a lot of Muslim women wear, also Muslim women, also Somali women wear to cover their hair. We have some custom-made ones being made for our children's patients and families, and also our employees, because what we noticed was if a family comes in, let's say something's been done to the hijab or some damage based upon an injury, we didn't have an opportunity for them to say, hey, here's a replacement hijab that you can use and even have at Children's, because we're going to make sure we understand your cultural needs and wellness as well. And also for our employees to make sure that they have the opportunity as well. So we are actually partnering with Halal's business and doing some great work there as well. The other thing I'll say is it's not just about race. We're starting with race as the focus, but it's also about making sure that LGBTQ families are welcomed and receive a welcoming environment. We have a wonderful gender health clinic run by Dr. Angela Geffer, making sure that that's important. And also too, making sure that we understand the different cultural needs around communication. And I put a culture appropriate music there too, because sometimes we use music as a way to soothe and address the needs of our patients and families. And a lot of times if you don't understand the different needs or the different likes of different cultures and music, you kind of stand short of getting an equitable environment for all of your patients and families. So that's important to that health equity lens. Some other things that are important is having culturally supportive partners. At Children's, I'm going to admit to you, we don't have a racially diverse nursing and doctor staff. We have 93% of our doctors and nurses and our patient-facing employees are white. Only 7% are people of color. We want to make sure that we change that, and we're going to do more recruiting at schools like Morehouse School of Medicine, Meharry School of Medicine, Howard University School of Medicine, which are predominantly Black, and more diverse, racially diverse medical schools. But in the meantime, we want to make sure that we partner with organizations like North Point Health and Wellness, like Minnesota Community Cares, organizations that are serving community that are more racially diverse than us, and making sure that we have those culturally supportive partners to make sure that we get some things done. And that includes neighborhood partnerships as well, and also making sure that we have the culture appropriate mental health and wellness and behavioral health needs being met as well in the school system. What is success? Real quick, another tool I'd suggest for you is what I call the 5 W's plus 3. You'll see the other plus 3 a little later. Ask yourself, what is this equity inclusion goal we're trying to hit? What are we trying to do in sickle cell to make a difference? If it's collecting data, that's one thing, but then what are we going to do with that data to implement better environment and culture for patients and families? Who's responsible for doing the work? This is one here where a lot of people tend to say equity is everybody's responsibility. It can be everybody's responsibility, but it's kind of like you consider budgeting in big organizations. it's everybody's responsibility to maintain a great budget, but you do have a CFO who's responsible for the organizational budget. It may be everybody's job to do marketing, but you do have a chief marketing officer or VP of marketing as well. So you have to have somebody leading this work, and in the children's case, that's me. You got to have the what strategies for implementing those goals. You got to have a win about when we're going to get this accomplished and stick to that timeline. And then also where you're going to head after you've achieved those goals. Think about equity and inclusion. It's a journey. And although maybe you hit your goals around equity and inclusion for sickle cell, we always have to be moving forward about how do we integrate that and do better. Here are my 3 W's that I've added on. I should just make them the 8 W's, I guess. But what are the best practices? What are some other things that other companies are doing? We're working collectively at Children's and other healthcare institutions with this group called CEO Action. And they're a group of over 1,000 CEOs around the world who signed on to a pledge for diversity and inclusion. And as part of that, 26 Minnesota companies have signed on. And part of that subset are healthcare companies that have signed on. So we work together to share best practices and ideas to address our patients and families' needs and making sure that we can address those. One of those that we're sharing with other organizations that we're doing, starting to do better at Children's, are service learning reports, which are quickly reports that can be made by patients or families or employees about things we need to do better around emotional harm for our patients and families or our employees. And we always measure before, our physical harm, like if there's collapses or other things that result in physical harm for patients and families. We're now measuring emotional harm to make sure that things like racism, things like bias are not getting in the way of success for our patients and families, our employees. And we're identifying those things in these learning reports that anyone can file. Once they're filed, they're investigated internally, and then we make sure that we address them on an individual basis, but also look at the system and how we can change it as well. We're sharing that best practice with some other hospital systems as well. Other things are, what supports do you need? I talked last about 2 or 3 slides ago about budget. You got to invest in this work. And then also too, how are you going to sustain the best practices going forward? If James Burroughs left Children's tomorrow, hopefully this work will continue. We have to build it into the system to make that happen. Here are just a few other things. These are particular to Children's that we're trying to do, promoting practices or eliminating practices that promote structural racism and health disparities. We have a policy committee for part of our Health Equity Council that looks at all of our policies through an equity lens to try to change that. Another one here I want to highlight, we're trying to provide our employees, patients, and families with everything they need to be successful, meaning recruiting diverse workforce, retaining that workforce, and also investing in community. And the other thing we want to do too is make sure that we approach every problem through an equity lens. As you know, healthcare has been negatively impacted by COVID-19 in the sense of record losses for healthcare institutions. But when we have to look at things like possible layoffs or furloughs or reductions, we're always looking into that through what's the impact going to be on underserved or traditionally underserved communities or racially diverse communities. So having an equity lens where we make those tough decisions is something that's important to us as well. What can you do? This is the final thing is establish your own measurable goals around inclusion, diversity, and equity, and relate them to sickle cell. Relate them to what are you going to do differently. If you're in this space and you're a partner and you're authentically working with Ray and the Sickle Cell Minnesota Foundation, what are your goals around that personally? What are you going to do to help patients and families access services better? What are you going to do to be more culturally relevant? There are tons of books, clothes, religious necessities, there's music, there's other things you can learn about. Do that as well. And I'll add to that bullet is expand your friend base and your colleague base. It's one thing to read a book about white fragility and racism. It's another thing to read a book about anti-racism. It's another thing to have that and then to don't have a racially diverse friend group that you're interacting with. A couple of the last ones here is listen to really listen. That's one of our values at Children's. So sometimes listen more than you talk. Be engaged with the community, and that means true engagement, not telling the community this is what Children's going to do to you, but instead saying, hey, this is what we want to do collectively together. And then lastly, learn new things. And with that, I want to thank Ray and thank you for listening, and turn it back over to Ray.
Thank you so much. Let's see, can you end your screen sharing? This has been wonderful. each of the 4 sessions has been amazing, but something about this month's session, because it was local, because it's all in our own backyard, that much more meaning for us. We are so grateful to have had Erica Barnes with the Chloe Barnes Rare Disease Advisory Council, being able to have Sondra Rosendahl with the Newborn Screening, Minnesota Department of Health, and of course our forever friend James Burroughs, the Chief Equity and Inclusion Officer at Children's Minnesota. We heard some incredible information here. So whether you are in a state or whether you are local and want to hear more about the Rare Disease Advisory Council, whether you want to learn more about newborn screening and all that's happening around newborn screening and sickle cell surveillance, or whether you want to better understand equity and inclusion and how that really plays a huge role in the work of sickle cell disease and in improving outcomes and in getting to the cure for all. You can always contact us at info@SickleSMN.org. I am pulling it up as we speak. But it is so important that we all work together. That was the theme of today, that together we are stronger. We all carry unique expertise and experiences, and when we put all of those together, we are a force to be reckoned with. We are in a unique time in our society, and specifically in our state, where we really must capitalize on the work that we are doing, and we must see our shared experiences and look for opportunities to work together. And this is a perfect example of how we are doing that and how we'll move forward to get to our goals. Thank you, James. You gave some very practical advice and steps in order to accomplish a more equitable world for all. And at Children's, they have, not only did my son get care there for 21 years, but I am now the sickle cell patient family advocate and care coordinator within the Cancer and Blood Disorders Clinic for sickle cell disease. And in the now almost 25 years that I have interacted with Children's, I've seen tremendous growth in the fact that your role exists and the work that you are doing along with the Chief Officer, Dr. Gorlick. I'm proud to be a part of that team as well as the sickle cell community. A couple of questions that came in, I'll try to summarize them. The first one, and you all can go ahead and unmute yourselves. Erica, is there a website or a email address for people who would like more information about the advisory council and the work that's going forward?
Yes, absolutely. Ray, I believe I can share my email address. We have a website where it's kind of still in process of being updated. So it's not, it's semi-live, but it's not quite ready for the big time. But what would be the best way? I'm happy to type my email contact.
Yeah, you know, I think that they can reach out to us for contacting any of you, since we don't particularly have a slide with it, but I think that's a great way that they can get involved, and then I can forward that information to you. So I will repeat our email address, and it is info@SickleSMN.org. info@SickleSMN.org. You can reach us there. And then we have a question for Sondra. Sondra, does Minnesota Department of Health or any other clinics offer free trait testing?
Minnesota Department of Health does not have free trait testing. I'm not aware if there's other clinics that do or not. We do have trait results for any individuals who've already been screened, but unfortunately only for children born from August 1st, 2014 on. We had a lawsuit a few years back where we had to destroy over 1 million blood spots and test results. So I know we've had a lot of families recently reaching out because their child is participating in collegiate athletes and they need that information. And oftentimes I have to let them know that we don't have that information and point them to where they could get it. But I'm not sure of any clinics that have it for free to test.
And right now, I can say pretty definitively that there are no clinics that are offering free tests. This is something that logistically, as a community-based organization, we are really looking into ways to make that happen. We know that sickle cell trait communications really didn't take form until 2015 for the state of Minnesota. That means that there is an entire community out there who either does not know that they have the trait, may not have ever been informed, has not had many of the conversations. And what we know about sickle cell trait and individuals with sickle cell trait is that they are in the highest risk category for having a child with sickle cell disease. It is not, it is, we recognize that there are very little complications with sickle cell trait, although there are some. We'll be doing more education around that. But what is important is that you recognize what your risk factors are if you are a carrier. And so we want to make sure that we are providing not just education, but also resources so that people can find out what their status is. And thank you, Sondra, you actually answered the second half of that question, and that is, where can I get a copy of my child's blood spot and for my other children if it happened before 2015?
So if it's August 1st, 2014, if the date of birth is that, we would have it. If the child was born before that, our first recommendation would be to go to the birth hospital and contact their medical records because we send all of the screening reports to the birth hospital. So depending on their retention records, they might have a copy of it. If they don't, I would recommend going to the child's very first pediatrician, because we encourage all hospitals to provide those reports to the primary care providers. And then if they don't have it, unfortunately, then testing is the other option.
Okay, thank you so much.
Yep.
And then James, I have two questions for you. The first one is if I am working with an organization that has not been able to meet with our hospital leaders, what is the best way to start that process to speak with individuals like yourself or others who are interested in making it a better environment for all? It's a long question.
I know. So use me. So I say other organizations have asked me to come in and speak to their leaders around what this equity work is and how they could possibly partner. And sometimes my voice is able to be stronger because I'm not worried about getting fired from your organization. I don't work for your organization. I can say the truth, and then I can help people process the truth into action. So I'd say that's one thing. The other thing is I'd highly recommend the CEO Action website. If you type in CEO Action, it'll pop up. There are a lot of different companies that have best practices about how to talk to and discuss with leaders this particular work. And the last thing I'll say is the Minnesota Hospital Association is doing some work now about putting together all the hospital systems in the state around addressing health equity. And you can get involved with that as well. So that's MHA, Minnesota Hospital Association as well. But whoever that was had the question, if they want to reach out to you, Ray, to reach me, I definitely could talk to them and also maybe share with their leaders some of the things that they can do.
Excellent, excellent. Thank you. The second question is, how in the world do you balance the type of work that you do and a caregiver to a young warrior?
What's balance? I don't know what that word means.
That's right.
So I'd say this. She keeps me honest. You know, she knows that Daddy works a lot. Her mom, let me give a shout out to her mom. So her mom, Tanisha Burroughs, we're co-caregivers. We're hashtag Team Teresa. So we make sure that her needs are met from a physical standpoint, academic standpoint, emotional standpoint. Because early on, she was like, Daddy, I have sickle cell, I can't do anything. She was like, you know, I get tired, I can't do this, but we had to reinforce that you can do anything and everything well. So it's a village, and it's also to many, many, many aunts and uncles that are not related blood-wise, but are related and more so caring about her, you being one of those, Ray, and Dr. Nelson being another, not just a provider, but a family member that helped do that as well. So it's rough. It's rough, but it's something that we need to do. And I want to implore, you know, people on this call and others to support the Sickle Cell Foundation of Minnesota. Because if you don't support it, and then when it goes away, and Ray's not gonna let it go away, but if it were to go away, then we'd be complaining about, man, we need to do something for our communities of color who are suffering from sickle cell. I don't want that to happen, and we're not going to let that happen. So let's continue to support this work and be there as well.
Thank you so much. That's so encouraging. And I'm actually glad that you said that about support. And yes, support, part of that is financial support so that we can continue the work that we do. But that support is also participating when there are calls to action. Specifically in the sickle cell community, we have a number of surveys that are happening where people want to hear from individuals who are living with sickle cell disease or caring for a child with sickle cell disease. These are not nefarious. It is not and their goal is not to misuse your information, but it really is to respect your voice and to give you a platform to share your experiences. The same can be said for clinical trials. There are, you know, when my son was born 24 years ago, I was not aware of even one. I didn't even know what a clinical trial was until he was in his teenage years. And even at that point, there was nothing available for sickle cell disease that we could reach out to. So now there are a number of new therapy drugs and curative therapies that are coming down the pipeline. But one of the best things that we can do is that we can participate in drug studies that involve us and that will be given to us. Yes, we have to be mindful about our rights. Yes, we have to understand what are the risks as well as the benefits. But if we don't participate, we will fall into yet another season of medicine that was not made with us in mind. It was not made with our participation. I am a strong supporter of FUBU. For those of you who are back in the 90s, you all know what FUBU means. That is for us, by us. That means we participate. That means our voice is known and our voice is recognized as a voice of influence and an informative voice and the voice of expertise in our community. Erica pointed out that, you know, we talk about medicine as a whole, but when it comes to the rare disease community, there are some very distinct and unique aspects of rare diseases, and then individual diagnoses, and then beyond that, individual households, because we are not monolithic. Thank you for saying that, James. We have, you know, we have overlap and we have gray areas that we are similar, but we will always have unique aspects of every single person that is important for providers to understand, but it's also important for us as caregivers or those living with the disease, because there's lots of information out there on the internet, and not all of that information is as concrete and factual as others. So when you have trusted sources and you have trusted relationships and partnerships, they really do go a long way. So,
and Ray, if you don't mind me, I can add real quick, and that's why health equity is so important, because the folks that you want to participate in clinical trials, they've experienced a discriminatory, racist, segregated, and also, you know, if you look at Tuskegee and other experiments that exploited people of color for a long time. So if you build in health equity, education, the fact that this is a partnership, folks will then say, you know what, I want to do this clinical trial because now Children's is a partner. You know, the state of Minnesota is a true partner. So we have to address health equity. So for the question that was asked earlier about the importance of it, how do you get people to understand it? If they want to diversify those clinical trials, it's important that we study or look at health equity as a tool to do that as well.
Thank you. Thank you. So true. One last announcement, as in case you all don't know, September is Sickle Cell Awareness Month. We are incredibly excited. There are a number of things happening in the sickle cell community, both locally, nationally, and globally. The Sickle Cell Foundation of Minnesota is shoring up some details regarding our signature event that will be happening, and so there'll be more details to come. You can contact us via our website, www.SickleCellMN.org, to stay up to date on that. But then there are also a number of other national things happening that now that we are virtual, we can participate in even from afar. So you have the Sickle Cell Disease Therapeutics Conference that's happening in September. You have the Foundation for Sickle Cell Disease Research conference that's happening in September. You have the Sickle Cell Disease Association of America, their conference that happens in early October, and many, many more. So I encourage you to go on to your Google and ask Google or whatever other search engines that you are using about sickle cell awareness in your state, and participate. We need your support. We want your support. Show up. You don't have to have sickle cell disease. You don't even have to know someone with sickle cell disease. You just simply have to care about the outcomes for all. So we encourage you to be well, to stay safe, and to demand justice for all. Thank you for joining us, everyone.